good evening, and thank you for joining us this evening as we bring you another edition of Operation Life Back to Basic. And what this series is really, we take those health conditions that disproportionately affect Black and Brown people across this nation, and we break them down for you. We make it simple for you because we have a goal. We want to shorten the life expectancy gap between Black and Brown people, Black and white people. So we have to do that. So we've got to get better care. We have to better understanding of those medical conditions. Also, we want you to be your own best health advocate. If you are armed with information that you can take to you when you go in to see your doctor about whatever condition you're suffering from, the more information you have, the more empowered you are with that information, the better those visits go and the better chance you have for having a successful engagement, not only with the healthcare provider, but also having a better engagement with that medical condition. And finally, it's really all about you. You have what we call a health span. And the healthier you can be along that health span, the better your lifespan will be. And so tonight, we are all about prostate cancer. And so we know that it disproportionately affects Black men in this country. The recent statistic I read today was Black men are 1.6 times more likely to get prostate cancer than any other ethnic group in this country. And Black men are twice as likely to die from prostate cancer than any other ethnic group. And so we're trying to give you the information. If it's not just for you, it'll be for your cousin, your uncle, your brother, your husband, to get that information to them so they can survive. So last thing I'm going to do, and we're going to bring on our special guest that we have with us this evening, is I want you to let us know where you're watching from. So drop in the comment section, let us know what city you're watching from. And if you have any questions throughout tonight's program, please drop those in the comments so we can try to get your questions addressed. This show is all about you and getting your questions addressed. So I'm going to shut up because you're not here to hear me talk. You're here to listen to our special guest. And tonight we have Dr. Mac Roach. He is a professor and he works at the University of California, San Francisco. Is that correct, Dr. Roach?
That is correct.
He is if you need to know about what's going on with your prostate, this is the man that you need to talk to. And so we are excited to have him here with us this evening. Thank you for joining us, Dr. Roach.
I'm honored. Yeah.
So the first question out the gate is a diagnosis of prostate cancer, should it be a death sentence?
It should not be a death sentence. Most men, first of all, the average age of the person who's diagnosed with prostate cancer currently is around 66. So it tends to come on at a point in your life where you're getting close to retirement, you're a Medicare patient, it's not for the younger people. I mean, you can see it in people in their 50s, even in their 40s, but the median age is 66. And most men that are going to have serious prostate cancer are getting close to 70 or even 80. So, and in terms of being a death sentence, the natural history of prostate cancer is quite long. So in many cases, even if you don't have any treatment, you can live a long time, but your quality of life is liable to decline if you don't get treated. So that, eventually it can kill you, but it tends to do so very slowly. So it's not a death sentence, and it can be effectively treated and cured.
Okay, so we're going to take it back to the beginning. What is the prostate and what is its function in our body?
So that's a good question. So the prostate sits between the bladder and the penis.
Okay.
So you get the bladder is like a bag. The urine comes from the kidneys, goes into the bladder, and then the tube that it goes through, we call the urethra, goes through the prostate, which is a round organ that sits below the bladder and before the penis. So when you urinate, when you pass urine, it goes through from the bladder through the prostate out the penis. And in terms of its purpose, it produces fluid. So the way that fertility works is sperm cells, the little cells that go to fertilize the eggs, those are made in the testicles.
Right.
And so when a man has an orgasm, nature wants those sperm cells to swim up and get into fertilize the egg in the woman. So the ejaculate itself tends to be sort of like a jelly material. Okay. And actually, we're going to talk more about it later. The PSA, which is a blood test that stands for prostate specific antigen. It's actually an enzyme that causes the gel to liquefy. So you get liquefaction of the ejaculate, which is probably involved in fertilization. So the ejaculate is produced largely, that fluid is produced by the prostate. So you get the sperm cells and the fluid, they come together. And then when they ejaculate out, the enzyme causes the gel to liquefy a little bit more and allows the sperm cells to swim up and hit the eggs and cause fertility to occur.
In my X number of years of life, I have never had an explanation of what the prostate actually does. I knew it was there. I knew it was part of the body, and I knew about prostate cancer, but I didn't know what it actually does. So thank you for that explanation.
Just a couple of more points about it. When a man is young, like, I don't know, you're kind of a young guy, but when you're like in your 20s, it's about 20 cc. So it's the size of a walnut. And the consistency is sort of like the palm of the hand. It's soft, it's round. And then as men get older, it gets bigger. And it goes, so by the time the average age for prostate cancer is about 66, at age 66, the average one is about 40 cc. So it's about twice as big as it was when you were a young man. And then as you get older still, it can get bigger. So it's not uncommon for a man to have 60 cc's or even 80 cc prostate. I've seen 150 cc prostate. So it gets bigger over time with age. The part that tends to get bigger usually doesn't have anything to do with prostate cancer.
Okay.
Because it's sort of like when you think of an apple, you have the part where the seeds are in the middle, and then you have the fruit, and then you have the skin.
Right.
And when you're really young, the fruit part is relative. That's where the cancer usually arises from in the prostate. It's the fruity part of the prostate, sort of like an apple. But as you get older, what happens is the part of the apple where the seeds are, that part grows. And that causes the prostate to get bigger, and it compresses the fruit part so that we call that the peripheral zone, the edge of the prostate. That part grows. And so that's why as men get older, they have symptoms when they try to empty their bladder. Sometimes they can't get the flow to go. Okay. Sometimes they can't empty it completely. So there are different symptoms that are caused by too much material that has grown in the middle part of the prostate to sort of slow the plumbing down. But fortunately, usually, although that's very common for men to have urinary symptoms, usually the cancer starts on the outer part of the prostate, so that it doesn't usually cause symptoms unless it's pretty advanced.
So we know, as I talked about in my introduction on this show, we know that Black men disproportionately are diagnosed with prostate cancer and disproportionately die from prostate cancer.
Yeah.
Why do you think that Black men are disproportionately get prostate cancer? Is there something that we can point a finger to?
No. So actually, no one knows why prostate cancer is more common in African American men. I believe, and there are a number of things that have been proposed. For example, we know that Black men tend to like their meat well done. When you char barbecue, or when you toast, anything that you char creates hydrocarbons, and hydrocarbons are carcinogenic. So some people say, well, maybe it's diet. There are people who think that it's genetic. I don't think it's genetic. There are people who think that it is related to viral infection. It's probably not due to viral infection. But if somebody put a gun in my head and said, all right, Mac, you got one shot at telling us what you really think the cause of prostate cancer is. This is going to sound strange. I think it's racism. I think that chronic stress causes suppression of immune surveillance mechanisms. So the problem with prostate cancer in terms of the excess death from prostate cancer is not unique to prostate cancer. If you're African American and you get cancer, period, you have a 50% higher likelihood of dying of cancer. So whether you're talking about breast cancer, uterine cancer, head and neck cancer, rectal cancer, Black people have a higher risk of developing, of dying of cancer if diagnosed with cancer than white people.
Right.
And we know that it's not a biologic phenomena that's fundamental, because if you take patients that are treated on randomized trials are where the patient comes in, you say, Mr. Jones, will you sign up for these two treatments, treatment A and treatment B? And you make sure everybody has the same kind of disease, everybody gets the same kind of care, all the patients are followed, then Black men and white men have the same survival rates. Okay. So if you get the same quality of care, you get the same outcome. In fact, there's some recent studies in which Black men do better than white men with treatment. And the interesting part of that is that one of those treatments involves a treatment that involves the use of a vaccine to treat prostate cancer. It's called Provenge. And it turns out that this is an immunologically mediated treatment. And it turns out that Black men did better than white men. And so that tends to support my hypothesis that what happens is that we have chronic stress, being a Black man in America, that chronic stress suppresses our immune system. Our immune system prevents us from developing cancer all the time. Your body is constantly being bombarded with carcinogens and other stuff. And if your immune system is intact, it will prevent you from getting the cancer. But if your immune system is compromised for whatever reason, then your body doesn't do as good a job of suppressing the development of cancer. So I think that racism in America, which is responsible for a lot of our stress, is the most likely culprit to be responsible for why we have a higher risk of prostate cancer. And one of the other reasons that I say that, there's a principle in medicine called Occam's razor. Occam was a famous British philosopher, and he said, basically, this is the layperson interpretation of what he said. If you have a person who comes in and they have a fever and they have a cough and they have a sore throat and they're having chills, then you feel like all of those symptoms could be explained by one type of infection. Okay. Occam's razor says if you have one explanation, one diagnosis that will explain all of the symptoms, then that's the most likely diagnosis. Now, you could also, a person could say, well, this person has a headache because they're having a stroke. This person is coughing because they have asthma. This person's having a fever because they have an infected bladder. I mean, you could come up with a different explanation for each one of these symptoms. That is much less likely. So when we look at, well, why do Black men have higher hypertension? Why do we have more diabetes? Why do we have more unemployment? Why do we get shot by police more often? Why do we have lower salaries? Why do we have a lower life expectancy? We have all of these things that are going on, and I can explain all of them with one diagnosis: racism in America. So I think the most likely cause for all of those things is the same thing, which is racism in America.
Well, that is real. I mean, because the little bit that I know is that that cortisol that gets released in the bloodstream when you are stressed has an effect on all of our systems. And so that's the layman's version. You just gave a great, a more detailed explanation of what that is. And so, so we're talking about in terms of just racism being a factor. How much of a factor is family history? Because I've already seen some comments where people are talking about brothers and uncles and family members that had multiple people in the same family that had prostate cancer. What role does family history play?
Well, family history is true of all races, right? So it doesn't matter whether you're black or white or whatever. If you have a brother or a father or your grandfather, the closer people are to you, if you have an identical twin, your risk is really high, right? If you have a brother who gets prostate cancer, especially at an early age, then your risk. So it's as high as like 7 times higher than it ought to be, in terms of if you, so family history is important, but most people that are diagnosed with prostate cancer don't have a family history. So if you do have a family history, you're at higher risk, but the lifetime risk of a black man being diagnosed with prostate cancer is somewhere between 1 in 5 and 1 in 7. So let's just say 1 in 6.
Okay.
And most of that cannot be explained by my brother had it, or my father had it, or whatever. It's just common. In fact, if you live long enough, you're likely to get prostate cancer. So if you see an 80-year-old man walking down the street eating a tuna fish sandwich, and you say to him, I bet you if I do a biopsy on your prostate, we're going to find a little bit of prostate cancer, you're about 75% right that there could be a small, little, tiny focus of prostate cancer. But probably the most important thing for the audience to be aware of is that prostate cancer comes in different flavors, different degrees and different severity. So you have some people that have a little bit of low-grade prostate cancer that some of us might even argue you shouldn't even think of it as cancer. It's just a little bit abnormal. And for those people, we usually do something called active surveillance. Once we do a biopsy and the pathologist looks at it under a microscope and says, this is a low-grade cancer, then especially if a man is 75 years old, he can just be followed, or 70 years old, he can just be followed carefully and evaluated. He get a biopsy to confirm that it's low-grade, and then he can be observed. Then you have people that have what we call intermediate risk prostate cancer, which means that they're not so low that you want to do nothing, and they're not so high that your prognosis is much worse, but it's sort of in the middle. And those people need to be treated, but the treatment tends to be less aggressive.
Okay.
So you, in that case, you don't need any drugs. Many times you don't need any medication. You can have radiation or you can have surgery. If you have radiation, we only need to radiate the prostate, right? We don't need to radiate the lymph nodes that drain the prostate. We don't need to give you any hormone therapy or anything like that. For men who have high-risk prostate cancer, these are cancers that when the pathologist looks under the microscope, they go, oh, this is a Gleason score 8 or 9 or 10 on a 10 scale. Those people need to be treated. And sometimes, for example, if they have surgery, they need to have surgery, and then they might need to get radiation after the surgery. And the same thing is that if they don't have surgery, if they do radiation, we will usually combine the radiation with medication that makes the radiation work more effectively. And the most common kind of medication that we would use in that setting is something that we call hormone therapy. Now, hormone therapy is, so men make testosterone, and testosterone is the male hormone. Well, it turns out that if a man, for whatever reason, for example, the eunuchs in China, they used to have these eunuchs. These were men that were castrated because they didn't want them molesting the women, and they were working in the castle. Supposedly, if you castrate a man early in life, he will not get prostate cancer. I don't know if that's really true, but that's what they say. Now, it turns out that I got a Nobel Prize for figuring out that when you reduce the testosterone dramatically in a man's body, the prostate cancer can regress. So even if it's already spread to your bones, your response rate is like 75 or 90% or something like that, that if you have your testosterone lowered dramatically, your testosterone level goes down. So normally a man's testosterone might be somewhere between 300 and 600, something like that. And then you can either take medication, or in some cases, the old days, they used to remove the testicles for very advanced disease. That testosterone will go from 300 or 600 down to 50 or down to 20 or less. And men who have bone pain, the bone pain will get better. So we also use that in combination with radiation in men who have high risk prostate cancer. So if the grade of the tumor is aggressive, that Gleason, we call it a Gleason score, 8, 9, or 10, we usually give the hormone therapy with the radiation. And it's sort of like, I don't know if you remember reading comic books with green kryptonite and Superman, right? You could take green kryptonite, expose it to Superman, it makes him weak, and then you could kill him theoretically, right? So when we take testosterone away from prostate cancer, it weakens the prostate cancer and it makes the radiation work better. So for men who have low risk prostate cancer, the first group I talked about, either active surveillance, just follow them, or sometimes in some cases we would want to treat them, but under no conditions would we typically want to give them hormone therapy. We just either remove the prostate or do radiation on the prostate. For patients with intermediate risk disease, those people that have the Gleason score 7, the PSA might be a little bit higher. Those people, if we do radiation, we'll give hormone therapy, but we only give it for 4 months.
Okay.
So short-term medication with radiation is very effective in the intermediate risk patients. In patients who have very high risk disease, these are people that either have a Gleason score 8 to 10, they have cancer which has metastasized to the lymph nodes, they have locally extensive disease, the cancer has gone from the prostate into the tissues around the prostate. For those people, we usually combine hormone therapy for sometimes 2 years, sometimes 3 years, sometimes lifelong, because the risk of dying is so great that it's worthwhile for the man who wants to stay alive to take hormone therapy for a long time. Now, when a man takes that hormone therapy, it does have a negative effect on the libido. And for those who don't know what libido means you're not interested in it. So if a man is on hormone therapy and he's 70 years old, he says, man, I wouldn't walk across the room to have sex. Or they'll see a pretty lady, they'll say, I used to, when I look at them, I would lust for them. I would look at them and go, man, I would sure like to hit that right there. Well, when that testosterone is gone from the body, the libido goes down and men are not as interested in sex. So for a lot of men, when they're treated for prostate cancer, they really are not enthusiastic about having hormone therapy added to their radiation. But if you explain to them that it improves the likelihood of cure and is associated with a better survival rate, then I can usually talk them into it.
So we're gonna come back to sexual functioning, but you mentioned 2 scores. We talked about PSA, which is the prostate specific antigen, and I'm going to put that on the screen so people can know what that is. Wow. And then you talked about the Gleason score, and so those are those 2 separate screenings, or are they both part of the same screening? So what are the screenings?
So the Gleason score is from the biopsy. So you screen with the best thing to screen with is the blood test.
Okay.
The blood test is PSA, prostate specific antigen. And that is on average for most people, a normal one is less than 4.0. That's the standard. Okay. Now, if you happen to have a strong family history and you have a PSA and it comes back 3.5 and you're 45 years old or 50 years old, you might want to think about paying a little bit closer attention to those PSA values, because although the normal is less than 4, what we have is a bell-shaped distribution of PSAs. So most men that are walking down the street, age 60, their PSA is like the last time I checked my PSA, it was 1.
Okay.
So most men that have their PSA is relatively low. It can be 0.1, it could be 0.3, it could be 0.4. So when it gets to be close to 4, you can, you start thinking about it, especially if you're a younger man, you might say, well, I'm going to check it sooner, or maybe I'm going to repeat it in 6 months, if it gets close to 4. On the other hand, you can have a PSA between 4 and 10. And if you have a biopsy done, only about 25% of men will have prostate cancer. So an elevated PSA that's above 4, a bit elevated, like 5 or 6 or 7, that does not mean you have prostate cancer. The threshold, so 4 is a threshold in which we consider sending the patient for a biopsy, but it doesn't mean you have cancer. Now, the biopsy is done under ultrasound guidance, where they take an ultrasound, they stick it in the rectum, and then they stick needles into the perineum.
See.
Yeah. So they do local anesthesia usually if they're a good urologist. And what they do is they take like 12 or 15 biopsies. So the prostate shaped like this, okay?
Right.
And so they take 2 biopsies from the bottom on the left and right, 2 biopsies on the mid site left and right, and 2 biopsies on the base left and right. So that's a total of 6 areas and 2 from each area. So on average, around 12. Now, if they see something suspicious, they'll take additional biopsies on the ultrasound. And then when they take those biopsies, they send the material to a pathologist. And the pathologist looks at it under a microscope. And there was a guy whose name was Don Gleason.
Okay.
And Don Gleason identified 5 patterns. 1 looks almost like normal prostate. 2 looks a little bit different. 3 is suspicious. 4 is definitely cancer. And 5 is really ugly cancer.
Okay.
So what happens is when you get a biopsy done, sometimes there's a little bit of one and a little bit of the other. So let's say they do the biopsy, the pathologist looks under the microscope and he sees a lot of the 3, right? That's it. Mm-hmm. This is 1, 2, 3, a lot of the 3, and then a little bit of the 4. He'll say that's a 3 plus 4 or a score of 7. That implies that the 3 is more than the 4. So if he sees more 4 than 3, then it's a 4 plus 3, 7. Now, a 3 plus 4, 7 is better for you than a 4 plus 3, 7. So the more 4 and the more 5 you have in the specimen, the more concern we have about the cancer being aggressive.
So that biopsy with the ultrasound and the needles and all that stuff, about how long does that normally take? How long does that procedure?
It's only probably 15 minutes. I've never had one. I don't do biopsies, but I would say, about 15 minutes or so. I mean, because they use a biopsy gun. They have a gun and it goes pow, pow. It's a needle that goes in there and takes the specimen. So it probably takes 15 minutes or so. And then you take antibiotics. You might have a little bleeding afterwards. Some people get infected. You can have infection after biopsy.
Okay.
If they do local anesthetic in the prostate, it doesn't hurt as much, but it requires a little bit more time because they have to take a needle, stick it in there, and then anesthetize the area before they biopsy.
Okay. All right. So then if you're watching and if you're just joining us, we're talking to Dr. Mac Roach about prostate cancer, and we're really having an interesting discussion. So we've learned what the prostate is, what it does. It can grow over time, and that's not necessarily prostate. That's just you getting older, so it can grow. We also know that the test is the PSA, which is a prostate-specific antigen, which is part of your blood test, and that should be below 4. But there's other factors, so that's just kind of one of the factors. But it should be below 4. And then if you at that level where you need to get a biopsy, then you'll get a Gleason score. And that Gleason score is really 5, but they can add it up, and that's why your Gleason score can be higher. The higher your Gleason score, the more probably problematic your prostate is. And so that's just kind of a summary of where we are if you're just joining us. And so now I've got to get that image out of my head of getting that biopsy done. So I can see right there that right there.
Well, getting the biopsy done is better than dying of prostate cancer.
but it's a mental hurdle that you have to kind of get over. And I can see how some men.
Well, but you also have to be aware that most men, so if you take 100 men and you screen, you do 100, you take PSAs of 100 men, 95 will be normal.
Okay. Okay.
So you have 5 men that have an elevated PSA, and then you biopsy them, and only some of them will be, a few of them will have cancer. And then it just depends on, and the likelihood of cancer depends on how high the PSA is. If the PSA is 4.5, then your risk of cancer is a little bit lower than if it's 10.5.
Right. Okay. So, Louisa, I'm just going to answer your question real quick. You get the Gleason score after the biopsy. That's you get it after. So the Gleason score is determined by the biopsy. So they take the biopsy results, they send it to a pathologist. He looks at it underneath the microscope, and then he determines what your Gleason score is, and then you'll get the results after the biopsy. So that's
correct.
Okay. So, all right. So now we've got an elevated PSA. We get the biopsy. The biopsy comes back. Our Gleason score is between 7 and 9. So the doctor says, "All right, it looks."
Well, it could be. I mean, it could be up to 10.
Up to 10.
So you can have 5 plus 5, or 4 plus 5 would be 9. So you add up the 2 components. Sometimes there's only one component there, like 4. 4 plus 4 is 8. But the risk goes up as it goes up. So you can have anything from no cancer all the way up to 10.
Okay.
And somebody just flashed a question, and I'm too slow with reading it.
No, it was they were repeating what you said. They were saying that again, getting a biopsy done is better than dying from prostate cancer. So
that's for sure.
Being uncomfortable for 15 or 20 minutes is way better than being 6 feet under.
And most men won't need a biopsy. So most men, like I said, the lifetime risk of developing prostate cancer is about 1 in 6. So most Black men will not get prostate cancer. So, but if you do have it, you want to know about it, and you want to know what to do about it. So if you have it and it's low grade, you might be a good candidate for active surveillance. But if it's intermediate risk, you should, if you're in good health, you might need to be treated. If it's high risk, you need to get prepared for that too.
Okay. So, all right. So you talked about some of the treatments. So let's kind of help our audience understand what the treatment options are. So I've heard hormones, I've heard medicine or chemotherapy, I've heard surgery where they just remove the prostate, or some combination thereof. Along those stages, what are the treatment options that people
have? Let me back up one point that we didn't cover that we had talked about before, which is, when should you start getting a PSA?
Good point.
At what age? So it turns out that I started getting my PSA at 35. Okay. That's not what the guidelines recommend. I just wanted, I was doing prostate cancer screening, and I said I should figure out what my PSA is. So it turns out that the American Cancer Society and some of the other organizations recommend that if you do screening, you should start at age 50. If you have risk factors, age 45. So African-American men, typically between 45 and 50 is a reasonable number. But if you have a family history, you could add another 5 years down on that. So if you have a family history and you're African-American, you might want to go at 40. Yeah. I like 35. And so the issue is that if your PSA is very low, let's say it's 0.2, then you don't need to do a PSA every year. You could do one, and you could wait a few years and do another one. And, and then as you get to be close to 50, you get to be my age, I could do one more often. But if it's low, if it's very low, like 1 is not so low. You can have a PSA of 0.2, 0.3, 0.4, like that. That's a very low PSA. Then you probably need to do it less frequently. But if you have a PSA that's 3.5 or 3.8, it's not over 4. You say, well, maybe I can wait a year. No, you might want to wait a month, or you might want to wait 6 months, or you might even want to go in because you might want to double check and see what your PSA was last year or 2 years ago or 3 years ago. because if your PSA 3 years ago was 0.8, and last year it was 2.5, and now it's 3.8, you could put that on a piece of graph paper, and that puppy is going up. Then you might want to think about being seen by a urologist and considering at least imaging. So sometimes nowadays, it used to be that I would immediately say, well, you should get a biopsy. But now, because of the availability of things like MRI, magnetic resonance imaging, you can image the prostate. And if the imaging is pristine, that is, the radiologist looks at it and says, we don't see any evidence of prostate cancer there. And there's something called the PSA density. So the PSA density, so if you have a really tiny prostate and your PSA, let's say your prostate is 15 cc's and your PSA is 10, that means the amount of PSA produced per gram of prostate is high. If somebody else has a 50-gram prostate, more than 3 times as big, and their PSA is 10, they have a low PSA density. So the likelihood of you having cancer is higher if you have a higher PSA density. So you want to know what your PSA is, and you want to know what it was. Because if you know what it was and you know it's going up, then you don't have to wait for it to be over 4 to think about investigating.
Absolutely. Okay. So I'm putting that here on screen. So just kind of track that sharp growth of your PSA. And that's really if you see some exponential kind of growth over time where this is going up and that PSA level is going up. That's when you should start thinking about other options. And the PSA density, which is something I never heard. So we're learning new things today. It's like I learned what the prostate does, and now I learn about PSA density because that makes sense. The larger the prostate, the more you're likely.
Well, the larger one could be benign prostatic hypertrophy, but it turns out that when you have cancer, you probably leak a little bit more PSA into the bloodstream. So the PSA density is higher when you have cancer than when you don't have cancer. But now you can have, the PSA can be elevated for other reasons. For example, if you have a bladder infection, if you have inflammation of the prostate, like prostatitis. Sometimes men have had episodes where they feel like they have to pee all the time, but they can't get it started and they have some discomfort. Sometimes that's just something called prostatitis, and that can be associated with a mild elevation of PSA. So, you need to, just because your PSA is elevated does not mean you have prostate cancer.
Okay. That's good to know as well, because I think sometimes if men start going to go get that PSA and they just get a high PSA result, it would help calm them down to understand and say, okay, let's take some other, it could be another factor. We got to rule those other factors out before we start jumping to cancer.
Now, one of the other things, I mentioned the MRI for people that have elevated PSAs. So I was involved in a program at the National Cancer Institute once, and the whole topic was active surveillance and whether, the role of active surveillance. And I was a speaker there, and we were in the back room, and then they had the audience out there, and they had a panel. So they kept us separate because they wanted to keep us away from the panel. The idea was to eliminate bias. So behind closed door, I'm there with a lot of speakers and experts on prostate cancer from all over the world. And we were having a conversation. Said, well, what would you do if you had an elevated PSA? And a lot of those guys said, I would get an MRI before I had a biopsy. Okay. And the reason that they said they would get an MRI before they have a biopsy is, first of all, there are some studies that suggest that a biopsy guided by an MRI is less likely to miss cancer. So when a doctor does biopsies, he only samples about 1% of the prostate. So if your PSA is elevated and the doctor does a biopsy and he says you don't have cancer, sometimes he's right and sometimes he's wrong, because sometimes he missed the cancer. But if you have an MRI first, the MRI frequently, if there's a significant lesion there of prostate cancer, you can figure out where it is on the prostate, and then whoever's doing the biopsy can make sure that they put a needle and try to hit that spot to make sure they don't miss the cancer.
Okay.
The other thing is that if you do the biopsy before you do the MRI, sometimes the biopsy itself will distort the images of the MRI. So when the needle goes in, it traumatizes the gland and you have bleeding in the gland, and it makes interpretation of the MRI a little bit more of a problem. So if I had an elevated PSA, I would get an MRI before I got a biopsy. But
Okay.
that's not standard of care. So if you're a Kaiser patient and you have an elevated PSA and you go to your urologist and say, well, I heard this doctor told me I should get an MRI before I get a biopsy. Well, they may not agree to do the MRI. They might say, well, you know, we don't do MRIs before biopsies. But I can tell you that if his PSA was elevated, he would probably get an MRI before the biopsy.
And that's the challenge of care, and that's why we're doing these type of programs, so people can have that and say, hey, look, I might need to go, you might need to seek a second opinion, but this is great information to know, because I'm thinking about my own family history. I've got my father had prostate, my grandfather had prostate cancer, and so I have a elevated family history. So like you, I started getting PSAs done at 35. Mm-hmm. And when I started getting those, they were still doing the digital exam at that point.
Well, we still do the digital. Well, not during the pandemic, we haven't been doing it, but we do it. The digital exam, 75% of people have a normal digital exam. So it's not that helpful. The blood test is much better. Now, at the very beginning, you asked me what caused prostate cancer. Why do Black men have a higher risk of prostate cancer? Mm-hmm. And I told you that we didn't know, and I thought it was maybe that racism had something to do with it. But there are some factors that are known to be associated with developing cancer in general that are also relevant to prostate cancer. So studies have shown that obesity, people that are obese have a 50% higher risk of developing cancer, and that includes prostate cancer. Okay. So obesity is a problem. And then there's some things that are associated with a reduction in the risk of prostate cancer, like exercise.
Okay.
So like I'm a runner. So I run, like Lake Merced in San Francisco 3 times a week, 4.6 miles. Part of the reason I do it is so I can eat more food and drink more wine. And the other belief is that exercise is good for your prostate. And also foods that are thought to be heart friendly. Okay. Are also tend to be associated with a lower risk of prostate cancer, but the data is kind of soft. But since it's good for your heart anyway, you get potentially kill 2 birds with 1 stone. So good diet, balanced diet. You don't have to be vegetarian, right. But probably you don't want to be obese.
Right. So if you're overweight or obese, lose some weight, and that'll lower your risk. If add more vegetables and more heart-friendly foods to your diet, and exercise. Those things seem to be a theme running through all of these programs we've been running.
Yeah, that's the other part. Is it's good for your diabetes, it's good for your hypertension, it's good for your stroke. It's just good for you,
It's
so you need to do those
you.
things. Yeah.
Diet and exercise. You're going to hear that theme. So if you're watching these programs, this is our 5th Operation Life program. On each one of these programs, we've had 5 different doctors on, and they all said diet and exercise will help control whatever condition that you are dealing with. And so please understand that, and we got to get healthier along the way. So that was another question, because I heard I remember my aunt cutting my uncle slices of tomatoes, because I heard about lycopene as being a kind of one of those elements that you could ingest and help lower your risk for prostate cancer.
Well, that's the Mediterranean diet that we're talking about there. But it turns out that the lycopenes have to be cooked. You're talking. So what you're talking about is the tomato sauce that comes from the tomatoes. It's not the raw. I mean, I love tomatoes. Tomatoes are good for you, so you're not going to lose anything there. But if you look at the data, it's that because in Europe, so-called Mediterranean diet, their incidence of heart disease, their incidence of prostate cancer tends to be lower with that diet that they have, which is high in lycopenes. But that's not the same as eating fresh tomatoes. But it certainly doesn't hurt you, and I like them. Now, you raised, before I regressed or digressed back in there, you were asking about treatment, and we only have about 15 minutes left. So I thought I would talk about that.
Yes.
So the two major treatment options for men who are being treated with curative intent are surgery and radiation. Now, there are other treatments. There's cryosurgery, where you do freeze the prostate. Mm-hmm. But cryosurgery is not recommended by the big organizations that provide guidelines. It's also associated with a very high risk of erectile dysfunction. So you have people that do it and they say it's less invasive. And actually, I would say it's more invasive in the sense that basically you freeze tissue and you destroy the tissue. So if you freeze something cold enough, you can kill it. Or if you heat something up hot enough, you can kill it. But there's no differentiation between normal tissue and cancer tissue. Okay. So you can damage normal tissue with freezing or heat, but it turns out that for reasons we don't quite understand, when you use radiation is preferentially damaging the cancer. So, okay. For example, if you have throat cancer of your vocal cords, and your heart's, and they look down there and the head and neck guy says, oh, you got cancer in your vocal cords. You can radiate the vocal cords, kill the cancer, and the vocal cords will work fine. And when we radiate the prostate, we don't destroy the urethra. It can be, it can become less. You can irritate the urine. I mean, you can irritate the bladder, and you can cause people to pee more. There can be some side effects, but you can give very high doses of radiation to the prostate and get rid of the cancer without necessarily damaging the rectum or the bladder or the penis. It can be done if you use the appropriate technology. So the two major options are surgical removal of the prostate or radiation of the prostate. There's also something called high-frequency ultrasound, which is sort of like another way of heating the prostate. Okay. Those things are not mainstream, and I really would not recommend them. Okay. Now, surgery, many urologists, so the urologists are the ones who diagnose the prostate cancer. That is, they're the ones that do the biopsy, and they send the biopsy to the pathologist. Excuse me. So in some ways, it's the pathologist who says it's cancer, but the urologist gets credit for making the diagnosis because he did the biopsy. Right. And so he gets the report back. So he's the first person to talk to the patient. And urologists get paid in most cases to operate on people. Mm. They also believe that the operation is very effective. And most of them believe that it's more effective than radiation. Now, it turns out that everybody has a right to their own opinion, but not their own facts. It turns out that studies have compared patients that got surgery and radiation in a randomized fashion, and there's no good evidence that surgery is better at curing prostate cancer than radiation is at curing prostate cancer. But some people will choose surgery anyway because they feel more comfortable with surgery. And that's perfectly okay. If you just feel like you want to have it cut out, then go ahead and have it cut out. That wouldn't work for me, but it might work for somebody else. Okay. Now, the downside of having the prostate cut out is that, first of all, it's an operation. So you have to undergo anesthesia, you have to be cut open. And typically these days they use a robotic approach, which means the hole is a bit smaller, but you still have to be cut and sewn back together. And when they cut, so as I described earlier, the bladder's here, it comes down, the urine goes from the bladder through the prostate and comes out the penis. When they remove the prostate, they have to connect the bladder to where the penis is. We call
Mm.
that area the urogenital diaphragm. And sometimes that sphincter that controls your urine doesn't work as well as it used to. As a result, men have incontinence. They leak.
Right.
Sometimes it's very minor. Sometimes it's not at all. Some men have great continence. Sometimes you have to have 3 or 4 pads a day that you have to change. You stick these pads in your underwear and you tend to smell like urine sometimes because of the incontinence. The other thing is that there's a tendency for erections to be compromised more than with radiation.
Okay.
So the operation the surgery is called a radical prostatectomy. That's where you cut the prostate out. When you cut the prostate out, it can be curative. Some people have a recurrence locally, even despite the fact it was cut out. But there's a higher incidence of you leaking and a higher incidence of you not being able to get an erection sufficient for intercourse. Radiation has a lower chance that you will be incontinent and a lower chance that your sexual function will be compromised. And that's the reason that many of the patients, especially Black men, tend to choose radiation more than white men. Okay, when they say if a surgeon says, well, the results are about the same with surgery and radiation, but sexual function is better than Black man. Wait a minute now, then I'm going that way. So I had a patient once, and I was explaining to him, if you have, there's a risk that you might develop impotence. And he was not familiar with the word impotence. Impotence is another way of saying erectile dysfunction, also called ED.
Right.
Also, so when I explained to him what it was, he said, "Oh, you mean no action on the Jackson?" And I was like, "Yeah, that's what I'm talking about. No action on the Jackson." So for men for whom sexual function and even their partners, where sexual function may be very important, then there's a tendency for men to choose radiation. Now, the other thing is that in men who have high-risk disease, locally advanced disease, when you're confronted with your treatment options, you really have to think of surgery and radiation versus radiation and drugs, because very few men with high-risk prostate cancer are cured by surgery alone. Many of them will require radiation after surgery. So you need to get that information. If you have high-risk prostate cancer, you need to check with your doctor and say, well, now this Dr. Roach, he said that if I have high-risk disease and I have surgery, there's a good chance I'm gonna need radiation and sometimes hormone therapy after the radiation. And if your doctor denies that fact, then you need to fire him and get a new doctor because he's lying to you.
Okay. So in the short amount of time we have left here, so when we're talking about surgery versus radiation in terms of treatment, and especially with regards to sexual functioning, we've heard people talk about milking the prostate and all this other things. Help us understand stages, because we hear stage 1, stage 2, stage 3, stage 4 in terms of cancer. What does that mean?
The staging system. So first of all, when I talk about low risk, intermediate risk, and high risk, it's really including the stages in there. Okay. It's just, I didn't use stages because low risk, intermediate risk, and high risk is a little bit more intuitive, that you know what you're talking about. I mean, that you understand that this is more serious or less. And doctors, we actually use that more than we use the stage.
Okay.
Now, the reason is that the staging system used to be terrible for prostate cancer because it did not include the PSA and it did not include the Gleason score. Because most staging systems for cancer, they're called TNM, tumor, nodal, and metastases. Okay. So when you're talking about lung cancer or head and neck cancer or some other cancers, you want to know, is it big? How big is it? Because they don't have PSA. They don't have the biomarker. And so they talk about, well, is it a T1 lung tongue lesion if it's this big versus if it's that big, a T3 or T4? So the staging of stage 1, stage 2, stage 3, stage 4 is more relevant to other cancers than prostate cancer,
Okay.
although you can use it in prostate cancer. So stage 4 would mean it metastasized already, but very few people have that at diagnosis. So you really don't want to be talking about stage too often. If you're being diagnosed with prostate cancer, hopefully you're stage 1 or stage 2, which is early stage, small tumor, no evidence of metastases. But most people who treat prostate cancer really talk in terms of low risk, intermediate risk, and high risk, which includes PSA and the Gleason score in the system.
Okay, so when you're going in for your exam, and you say you got low risk, intermediate risk, and high risk, that's what you're looking for, not in terms of staging. Staging's for other cancers.
If they tell you you're stage 1, that's low risk.
Low risk, right? So you can.
If they tell you you're stage 4, well, you got metastatic disease, but that's not usually, because 75% of people. Part of the reason that the staging system is not so relevant in prostate cancer is that for most tumors, let's say you have a breast cancer, there's a lump, and T1, T2 depends on the size of the lump. But in prostate cancer, 75% of men diagnosed with prostate cancer, when you do a rectal exam, you don't feel any cancer.
Right. Okay.
So the T stage doesn't really matter much in that case because it's going to be low. It's the T1. If you don't feel anything, it's T1. If you feel something, but it seems to be confined, it's T2. But if you feel something and it feels like it's going from the prostate into the fat around the prostate or into the seminal vesicles of the prostate, then it's T3. If it invades the rectum, it's T4. But most people don't have that, and so it's not so useful to even talk about it.
Got you. So last question, so we can get you out of here, and the time is, what questions, when they go in and you're going in for your prostate, how often should you be getting screened? Is it an annual or semi-annual? And then what questions should somebody be asking, particularly if they have a family history of prostate cancer?
So the lower your PSA is, the less frequently you need it. But typically, and the higher it is, the more frequently you need it. So even though it's normal, if your PSA has gone up a little bit, if it's 3.5 and the other year was 2, then you want to do it more frequently. I mean, in most cases, people have talked about annual PSAs. But if your PSA is very low, you don't need it annually. You probably could go every 2 years or every 3 years. So, and what was the other question?
What questions should they be asking their doctor when they're?
Well, first of all, you should ask for a PSA. Some of the guidelines say that some of the guidelines don't recommend PSA screening. Some doctors follow those guidelines. And at Kaiser, I believe they stopped screening. Their policy is to stop screening at either 65 or 70. So they won't even tell you that they stop screening. They just will stop screening. So let's say that you're, and I know of a patient that, his PSA was slowly going up, and then he reached a certain age and they stopped screening him. And subsequently, he was found to have significant prostate cancer. So you should be proactive. I think that you should be screened. It doesn't mean you should be treated if you get diagnosed as having low risk disease. You might want to do active surveillance. But I do recommend that Black men get screened for prostate cancer. Okay. So the main take-home message is, when you go see your primary care doctor, don't ask him whether he thinks you should be screened. Tell him, I've been watching, I've been listening to things. I would like to be screened for prostate cancer, period. Right. And the other thing is that nowadays people have access to their own electronic medical record. So you should learn how to get into your own chart. And if you learn how to get into your own chart, then you can look back over your PSAs that you've had over the last 10 years, and you can look and see if there's a pattern. Trying to ask somebody to remember what their PSA was 2 or 3 years ago is a little bit much to ask. But if you can look into your electronic medical record, then you can keep track of your PSA, your cholesterol, all kinds of things.
And that is a great point, and a point that we're gonna end on is that please check your electronic medical records, understand what all of your numbers have been and how they have changed over time. So if you notice that your blood pressure has been elevated this year versus last year when you've gone in, you might want to just say, okay, check that out. Cholesterol levels, PSA levels, all of those things, you can check it yourself and be armed with that information so you know. Because understanding this, if you're going for an annual appointment, you're going to see your doctor maybe an hour out of a year, right? And so
hour.
I'm being
optimist. Maybe in private practice.
I'm being liberal on that hour.
You'd be lucky if you get 15 minutes.
I've been counting the whole visit. I'm counting.
Yeah, okay, all right. You're talking about how long it took to find a parking place.
But the point is that the rest of that time is you, and it's up to you. What do you eat? What are you ingesting? That carcinogens, the well done meats, and that's good to know. Are you exercising enough? Are you, if you're obese, if you're overweight, what are you doing to lower your weight? Because every time you lower your weight, you can improve your health situation. So there are things that you can control, and please take as much control as can. So Dr. Rhodes, this has been informative. It was a little scary when you start talking about biopsies, needles, and stuff like that. But this is important information that we've got to know in order to lower that gap. When we're talking about Black men being twice as likely to die from prostate cancer, and as we open the show, excuse me, this is not a death sentence. It only becomes a death sentence if you do nothing about it. And so that's the message we want to leave you with today. It is not a death sentence, but you have to do something about it. So again, after this program, share it with your friends, tag someone that needs this information. It'll be re-aired tomorrow morning, and it's also going to be on our YouTube channel. So make sure you check it out. Thank you, Dr. Roach, and thank you everybody that joined us this evening.
All right. Take care, everybody. Stay safe.